Hello, my name is Andrew Schroll, and in this scenario, I'm going to be playing the role of a CRNA that's going to be precepting a junior. And now this junior is now starting to go 3 days a week. It's now 3 p.m., it's the end of the day, and we're going to discuss a few issues that we had throughout today, along with going through the FIU evaluation log, which I have here in front of me, in order to go through a stepwise procedure of what can be improved, going forward. So, first thing we're going to discuss with the student is a few incidences that occurred. So the SRNA did arrive at 6:45 for a radical cystectomy in the morning, whereas the CRNA, arrived at 6 a.m., so it's a 45-minute difference. And one of the things we're going to have to discuss is why this lack of preparation for the case, because you're not going to be able to get ready for the case in 15 minutes if it's a 7 o'clock start. So we're going to have to discuss, why the student happened to do that. Was it on purpose? Was there a car accident? Was there some type of unforeseen incident, or is this something that occurs on a regular basis? Because if so, it's something we're going to have to work on going forward, because as a CRNA you need to become prepared to the case, and this requires coming in early, making sure the room is ready, following your standards of according to the ANA, which includes machine checking and make sure everything is done, get a good thorough pre-op, have a good understanding of your plan and how you're going to execute this plan. So for a radical cystectomy, for example, it's important to know this could be a 4 to 6 hour case. Your EBL is going to be 400 to 1500 mLs, and you're probably going to need some blood tubing. You're going to need an A-line. You're going to need at least 2 peripheral IVs. And if we have a 7 o'clock start, there's no way you're going to be able to accomplish all of this within a 15-minute time frame. So I'm basically explaining this to the student, and I'm going to ask for some feedback. Why did you show up late? Did you think you were going to be able to accomplish all of these tasks in advance? And this also goes into whether you have a care plan or not, because if you have a care plan, you understand what needs to be accomplished throughout that day, or for that at least for that specific case. So this kind of leads me into, let's look at the care plan and let's see exactly what you did for the care plan and what you really anticipated going into this case. Next issue we have is the student was texting, for personal reasons during the case. And unfortunately, you might see this with some professionals, and it's not the right thing to do. Our responsibility is to maintain our focus on the patient at all times. This is one of their most vulnerable moments while they're in surgery. So things could happen very quickly, and we need to be attentive and be able to anticipate issues. And especially as a junior SRNA, your reaction time is going to be much slower than someone that's been doing this for 10 years. So you need to be especially alert in order to anticipate things as they come about. So I think it's really important to stay alert and really try not to get distracted during these cases. Next issue we have here is that the student found that the patient was allergic to penicillin, yet still was drawing up ANSEF. Now, of course, if your patient is allergic to penicillin, there's a high likelihood that they're going to have a reaction with other cephalosporins, such as ANSEF. So it's very important that you consider alternatives like vancomycin and discuss this with the surgeon, prior to administration, of course. So that's something that you need to understand, even from an ICU standpoint, that you don't give drugs without fully understanding them. Or if there's an allergic reaction that the patient has, you really need to fully understand that before you administer any drugs. So never administer drugs before or without having a full understanding of what they are and what they may react with. Another issue is that the patient gave 5 milligrams, was supposed to give 5 milligrams of ephedrine and instead gave 5 cc's, equating to 25 milligrams of ephedrine. Now, of course, this is way too much. It's literally 5 times the dose that was anticipated. This is a medical error, just like if the student was working in the ICU. So if you give 5 times the dose you're intended, that's a medical error. That probably requires an incident report, and based on whatever the facility's policies are, you'd have to follow those. But more importantly, it's the patient's safety. So always use closed loop communication. So if I ask the student, please give 5 milligrams of ephedrine, the student must in turn say, all right, administering 5 milligrams of ephedrine, he may want to show me the 1 cc in the syringe so I understand exactly what the SRNA is doing. Or they could vice versa say, 1 cc. But unfortunately, sometimes professionals will say, give 5 of ephedrine without really considering the mLs or milligrams. And for students, it could be a little confusing. Sometimes they're a little intimidated to admit they don't know which one is the appropriate dose. So it's very important to have closed loop communication and really specify with medications so that you prevent errors and promote patient safety. The next issue we had is that the patient was in a steep Trendelenburg and was on volume control and had high peak inspiratory pressure. So we're going to want to talk to the student, ask why, did this patient obviously had high peak inspiratory pressures, and what could we have done differently to prevent that? And what are some of the risks of having high peak inspiratory pressures? So I would go through and explain that to the student, and so that they understand, we're increasing the pressure basically because of gravity from the abdominal contents into the lungs. You're going to have decreased tidal volume, decreased FRC, and you're going to have an increased closing time. So it's very important to understand these concepts and really go through them in order to have better patient safety, throughout the case. And then lastly, or almost lastly, along emergence, you need to basically have an OPA or some type of oral bite block in place. And the really key thing to understanding here is negative pressure pulmonary edema and how this could be a life-threatening complication, especially in young people that are able to take markedly deep breaths. This could be potentially dangerous for them. So, especially for these people, it's very important that you understand this concept. So this is something that we're going to have to go through and really be able to articulate, before we do another case together. And then upon emergence, the patient was on pressure support and only had 0 twitches and was already administered neostigmine and glycopyrrolate. Obviously, this is not appropriate. So, I'm not going to go ahead and say obvious with the student. I'm going to try to be a little bit more sensitive to the student, and I'm going to be very attentive as a preceptor, watching what's going on in order, to maintain patient safety. So I'm going to try to stop any of these things, obviously, from occurring. If I'm in the case together, we're going to have to understand that you need at least 2 twitches, for neostigmine. According to the book, you could have theoretically 1 that is stronger, at least by 10% above baseline, but you really need at least 2 twitches for neostigmine to work effectively. And you're not going to be on pressure support, which you have to understand your ventilation settings if you're really going to be managing anesthesia for this patient, because if the patient has no twitches, that means they're not able to breathe on their own, and pressure support is not really the appropriate ventilation setting for this patient. So in this case, if this were to happen, there's areas that can be improved in terms of managing your paralytics. You're going to want to give Sugamidex, in this particular instance. But, going forward, we're going to try to manage our paralytics and to kind of time it with the case, understanding when the case is starting, key events throughout the case, on when we could actually administer neostigmine appropriately, or how much paralytic is appropriate really to give, throughout the case in order to time the case properly. So basically, I'm giving closed loop communication, to kind of debrief here. Closed loop communication, we're going to have some effective learning going on here. Again, we're debriefing about this situation. It's important to understand some of the barriers. Maybe there's some issues of why the student might not be progressing as you intended. So we got to discuss those. And, I'm also going to talk about some of the positive things that the student's done. So for example, the student has been very professional, has been showing good teamwork, asking questions. So there are many positive things that you have to enforce. You can't just discuss negative issues. You do have to enforce the positive ones as well. But setup and preparation, like we discussed, can be improved according to the anesthesia evaluation, the FIU evaluation log. Patient preparation and assessment, again, you need a little bit more time, so try to get in a little early, and we're going to work on that for next time. Knowledge base, again, with the ventilation setting and some of the issues we already discussed, that definitely leaves some room for improvement. Application of knowledge base to anesthetic practice, again, some of the issues we discussed, with time will come, but you do need to study and prepare for these cases a little bit more thoroughly. Psychomotor skills, the student did great, was able to get the IV, but, there's some things that we need to work on, like inserting an arterial line and, some of the more advanced skills that, students at this level are still trying to master. Again, like I said, communication was good. The student was asking a lot of questions, so I really appreciate that. Was honest about what the student didn't know. So that's something that's good. And then the student was professional. So overall, there is some room for improvement, but the student did well, and I look forward to working with the student again.